Radiotherapy and radiosynthesis. Definition: radiotherapy is a therapeutic use of ionizing radiation, typically using high-energy X-rays. Radiation is the process of emitting radiant energy in the form of waves or particles. E equal to hf, where h is Planck's constant, f is frequency of wave. Energy is measured in MeV in RT. Gamma ray and X-ray have same energy level except the source is different. Mechanism of radiotherapy. Radiations act on biological cells by ionization, which can be direct or indirect. Direct ionization, photons hit matter and produce secondary electrons which can damage DNA directly. Indirect ionization, photons hit matter, produce secondary electrons which produce water and oxygen, free radicals. The free radicals then damage DNA. Indirect ionization is more common. It is also cause cell reproduction failure by inhibiting mitosis. This is a picture showcasing mechanism of radiotherapy. DNA damage in mammalian cells triggers three pathways: cell cycle arrest, DNA repair, apoptosis. Historically, three types of damage have been recognized: sublethal damage, potentially lethal damage, irreparable or lethal damage. They reflect the category of repair process that act to modify the radiation-induced lesions. If DNA damage is particularly severe, then cell death may result when the cell attempts to divide. Tissues such as bone marrow, skin, and mucosa of upper aerodigestive tract manifest the effects of radiation within days, as does acute-reacting tissues. Connective tissue, bone, and neural tissue may only show the effect years later, hence being defined as late-reacting tissues. Squamous head and neck cancers view as an acute-reacting tissues like the squamous mucosa, from which the originating tissue to kinetics of the population, the response of tissues and organs also dependent upon inherent cellular radiosensitivity. The sensitivity of cell to radiation is also determined by its maturity and its functional role. Immature cells are considerably more sensitive to radiation than mature cells, and as somatic activity increases, sensitivity also increases. If any clonogen from acute responding normal tissues survive, they can rapidly repopulate and replace lost cells. Late acting tissues do not have this ability to repopulate rapidly, and therefore when most acute reactions heal, most late reactions, if anything, may continue to progress with time. It is severity of predicted late effects then can limit the delivered dose of radiation. Fractionation. A fraction is the individual dose of radiation delivered at a single session of radiotherapy. Fraction size measured by physical dose is almost invariably constant throughout a course of radiotherapy. In conventional radiotherapy, fractions are given once a day, 5 days per week, typically for 4 to 6 weeks. At low single doses, tumour and early responding tissues are more sensitive than late responding tissues. At high doses, a non-dividing late responding cell response that compensates for tissue loss is slow, and therefore organs appear more intrinsically radiosensitive than rapidly dividing tumour and early responding tissues. Relation between dose of radiation, residual fraction, and the number of cells killed approximates close to straight line, a semi-logarithmic graph. Conventionally, drawing dose are typically on x-axis, surveying fraction of cells on a declining logarithmic scale on the negative y-axis. While the general relationship is linear at the lowest doses, this is not so, and the line is curved. For most cells, the ranges which the shoulder applies is close to most widely used fraction sizes. Late reacting tissues generally have a more curvy graph than acute reacting ones. The shoulder on the graph is a reflection of a capacity for DNS to repair damaged cells. The cells from patients with ataxia telangiectasia show almost no curve. This is because the patients are deficient in certain mechanisms that act to repair DNA. The general shape of cell survival curves, including Shoulder is probably best described by linear quadratic equation. S equal to n by now. N is the number of cells in the population originally, and n is the number of surviving after irradiation density. N by n ratio representing the surviving fraction. Only two parameters, alpha and beta, required to describe the dose response curve. Absolute values of alpha and beta are not well known, but the alpha beta ratio or non has been identified with reasonable degree of approximation for numerous tissues. In general, the alpha beta ratio tends to be low for late reacting tissues, and for the shoulder on the graph is considerable, whereas it is high for acute reacting tissues. Where the shoulder is less marked. When this is translated into practice, the total effect is more fraction size dependent for late reacting tissues than for acute reacting tissues. Having said this, because of the ability of early reacting tissue to repopulate rapidly, these comparisons are only valid if the overall treatment time is the same for different schedules. Contractibility of head and neck squamous cells carcinoma like acute reacting normal tissues will negate the intent benefit. This will necessitate a shorter interfraction interval for schedule of many small fractions. This interval still needs to be low enough for adequate repair of sublethal damage to occur if the full sparing effect on late reactions by reducing factor size is to be seen. Better local contact was achieved in the experimental hyperfractionation arm with no observed increase in the late side effects. This approach to improve the therapeutic ratio, however, has not gained wide acceptance in radiotherapy community, largely on logistical grounds. Other ways of modifying radiotherapy fractionation schedules have also been explored in head and neck cancer. Problem of tumor clonogen proliferation during a prolonged course of radiotherapy has already been alluded to. The consequence of this is that if radiotherapy schedules are prolonged for reasons such as Hald's machine, that turns on tumor control is adversely affected. Radiosanitizers. Numerous types of agents have been used with varying degrees of success. Rapid advances that are currently occurring in molecular oncology have made and continue to make this an area of fruitful exploration. Evidence that emerged from laboratory studies that hypoxic cells were relatively radio-resistant to X-rays when compared with fully oxygenated ones promoted the earliest attempts of radiosensitization. The earliest avenue explored was probably the most direct. In an attempt to ensure greater oxygenation with tumors, patients were placed in hyperbaric oxygen tanks during radiotherapy. Clinical trials results failed to demonstrate that this approach yielded better results than standard radiotherapy. There have been reports that increasing the hemoglobin level can be beneficial as anemic patients may respond less well to radiotherapy. Initial studies suggest that those patients given transfusion and hyperbaric oxygenation did better than those given hyperbaric oxygenation alone. However, the subsequent results from DAHANCA study group did not support this. Studies with recombinant erythropoietin have discounted the anticipated benefits of using erythropoietin to correct anemia, with such patients actually faring less well. An alternate approach used the agent nicotinamide, which is thought to dilate small vessels to improve blood flow through vascularized parts of tumors, in combination with patients breathing carbogen, a mixture of oxygen and carbon dioxide, during radiotherapy in an attempt to ensure good oxygenation and thus deal with the chronic hypoxia. Combined with accelerated radiotherapy, this approach called ARCON was tested in a phase 2 trial in promising local control. A phase 3 trial showed local regional benefits with acceptable toxicity but no gain in overall survival. A number of parasitimal approaches have been used in an attempt to make hypoxic tumor cells more irridosensitive through more direct actions on the cellular structure. True sensitizers have little or no cytotoxic action without radiation, but significantly enhance the efficiency of radiation killing when present during radiation. Apparent scientists include a variety of compounds such as antibiotics, alkylating agents, and antimetabolites that act by diverse mechanisms. In general, scientists can be regarded as agents that increase lethal effects of radiation. They should show a gain between tumors and normal tissues. Such therapeutic gain could result from selective uptake, differential absorption rate, and or biological half-life. Ideally, they should be effective at symptomatically non-toxic dosages, thereby minimizing side effects. Halogenated pyrimidines work by being incorporated into actively dividing tumor cells to a greater degree than slowly dividing normal tissues. They therefore seem to be particularly useful with tumors having a high growth fraction and high leveling index. BRD-URD is also sensitized to ultraviolet radiation, therefore skin may be the limiting tissue. This is less a problem with IUDLU. Hypoxic cell sensitizers are electron affinic and act to increase the sensitivity of radio-resistant hypoxic cells by mimicking O2. They are not rapidly metabolized and therefore have time diffuse into poorly vascularized areas. Cells are more responsive to sensitizers if they are depleted of the natural radio protector glutathione, a radical scavenger that eliminates reactive radicals before they have opportunity of causing DNA damage. This may be accomplished by incubation with thiol binding agents such as diamide and diethyl malate or inhibition of AHS synthesis with butadiene sulfoxamine before delivering the radiation. The effectiveness of hypoxic cell sensitizers is measured in terms of enhancement ratio. The nitroimidazoles have been extensively evaluated as potential radiosensitizers. One of the first compounds investigated was metronidazole, a trichomonoxide at 10 mm and enhancement at 10 mm and ER of 1.6 was obtained with no effect on aerated cells. The large concentrations required led to investigations for more effective derivatives, and other nitroimidazole drugs appeared more promising in this respect. Although many hypoxic cell sensitizers have been investigated, controversy exists regarding the role of these agents in conventional radiotherapy. So far, only one major randomized trial of the many that have been performed have shown a therapeutic benefit, and in this DAHANCA trial, a benefit for numarazole use during radiotherapy of pharyngeal and supraglottic laryngeal cancers when combined with conventional therapy was shown. Although numarazole has been shown to be of potential benefit, these sensitizers clinically show greater benefit in situations where large single doses of radiation are given. As well as this one trial out of many have shown a statistically insignificant benefit. The international clinical community remains unconvinced that there is a true benefit for the use of nitroimidazoles, and they are still not widely used outside Denmark to this day. To be continued. Thank you.